Hi, my name is Massa, and this is my patient care presentation on hypertensive emergency for Nursing 217. This slide gives the background information on a complex patient that I experienced during one of my clinical rotations. This patient was a 62-year-old African American male, full code with no known allergies. So he was admitted after he called emergency medical services on himself for severe abdominal pain. He was found by EMS while falling and having a seizure. During his seizure, he bit his tongue and suffered from a severe tongue laceration with significant oral bleeding. Other admission findings included a systolic blood pressure greater than 240 and a potassium level of 6.1. It was then discovered that he had missed 2 rounds of his hemodialysis treatment. On assessment, he had a high pain rating of 7 and greater, bilateral lower extremity edema, and scattered ecchymosis. This patient had a past medical history of chronic kidney disease, diabetes mellitus, hypertension, and hyperlipidemia. He was admitted to the hospital with being in a hypertensive emergency. These next few slides provide research from my literature review. This slide gives some standard demographic data as well as incident rates of hypertension. In a study done by Frederick Waldron and others, they found that the overall prevalence of hypertension worldwide is 30 to 45%, and specifically in the United States, 1 in 3 adults have hypertension. In a second study done by Mistega and others, they looked at the prevalence rate of hypertension among adults aged 18 and older in the United States between 2017 and 2018. They found that hypertension was higher in men than women, it increases with age, and was higher in non-Hispanic blacks than in Hispanics and non-Hispanic whites. The specific percentages are provided on this slide. So these graphics illustrate the data that was provided on the previous slide. The first graph on the left displays the prevalence of hypertension by sex and age. Men aged 60 and over had the highest prevalence at 75.2%. The second graph on the right displays the prevalence of hypertension by sex and race. Non-Hispanic black men had the highest prevalence of hypertension at 57.2%. So with this research, I was able to see that my patient fell into a lot of these categories where the prevalence of hypertension was the highest. So a person is said to have hypertension when their systolic blood pressure reaches to greater than 130 to 140 and their diastolic blood pressure is greater than 80 to 90. Hypertension can then progress to become a hypertensive crisis when the systolic blood pressure is greater than 180 and the diastolic blood pressure is greater than 120. A hypertensive crisis may then present itself as either hypertensive urgency or hypertensive emergency, as shown on the slide. In an article by Latoya Brathwaite and Max Reif, they describe a hypertensive urgency situation as not having end organ damage, but rather symptoms of headache, anxiety, and upset stomach may be experienced. On the other hand, a hypertensive emergency occurs when there are signs of end organ damage and immediate treatment is necessary. So my patient fell into the category of having a hypertensive emergency. His blood pressure when admitted was greater than 240 over 120, and he was showing signs of possible brain damage presenting with a seizure. So there are different types of hypertensive emergencies, and one type is hypertensive encephalopathy. Hypertensive encephalopathy is triggered by poorly controlled hypertension and is characterized by signs of cerebral edema. So what I think happened with my patient is that his 2 missed hemodialysis appointments caused him to experience a severe increase in his blood pressure that led him to having a hypertensive encephalopathic event that presented as a seizure. What normally occurs is the brain will sustain blood flow within a narrow perfusion pressure range without being affected by changes in blood pressure. When mean arterial pressure increases, arterial vasoconstriction occurs, and when it decreases, arterial dilation occurs. The brain follows this adaptive process to maintain brain perfusion at a constant level. So in my patient's case, his severe increase in blood pressure exceeded this autoregulatory mechanism and caused vascular fluid to enter into the brain tissue. This leads to cerebral edema and can cause neurologic symptoms like a seizure. Terence Potter and Timothy Schaefer mention that hypertensive encephalopathy is not very common and majority of patients have a blood pressure of greater than 220 over 120, which my patient had. The good thing is that with prompt treatment, it can be reversible and symptoms can be resolved. These next few slides will go into the plan of care. Patients experiencing a hypertensive emergency need to be admitted to the ICU for close monitoring. When in the ICU, the goal is not to achieve a particular blood pressure value, but rather to preserve organ perfusion and prevent hypertensive organ injury. Blood pressure should be lowered in a controlled manner with a reduction in systolic blood pressure not more than 25% in the first hour. In the following 2 to 6 hours, the blood pressure should be gradually lowered to 160/100, and over the next 24 to 48 hours, the blood pressure should return to baseline levels while in the ICU. So this slide provides some of the medication treatment that is done to gradually lower blood pressure. In a few articles I found, they listed that the most efficient drugs for treatment of hypertensive emergency included nicardipine, clevidipine, labetalol, and esmolol. In the ICU, the patient is started on IV medications because of their fast onset and ability to be titrated. Then the patient must be stabilized and have an improved blood pressure for several hours before being able to transition to oral antihypertensive medications. The column on the right of this slide shows the medications that my patient was taking. At the time I was involved in my patient's care, he had stabilized enough to transfer from the ICU to the telemetry floor that I had my clinical on. He was taking 2 oral antihypertensive medications, clonidine and fetapine. He also had Protonix for acid reflux and insulin for his diabetes. In addition to these medications, he was also prescribed 2 PRN blood pressure medications, hydralazine and labetalol. Throughout my clinical day, his blood pressures were still higher than normal. I stayed in communication with the nurse of this patient and monitoring his blood pressure and whether or not we needed to give him the prescribed PRN hydralazine or labetalol. His situation became tricky in making sure the medications were helping lower the blood pressure, but also to make sure not too much medication was being given where it would cause his blood pressure to bottom out. So on this plan of care slide, I included the nursing interventions that need to be implemented when caring for a patient recovering from a hypertensive emergency. Education is a major intervention that needs to be done for these patients, especially on treatment compliance. In a study done by Nerton Ozen and others, they found that patients with chronic kidney disease caused by uncontrolled hypertension had a significant increase in hospitalization and mortality when they failed to adhere to their medication treatment, hemodialysis, and dietary and fluid restrictions. I knew that proper education was being delivered to my patient when he told me that he was never going to miss a hemodialysis appointment again and that he was going to work hard to follow a renal diet that was low in sodium and try and include more fruits and vegetables in his diet. During my clinical experience with this patient, my goal for him was to lower his blood pressure. I educated him on the importance of monitoring his own blood pressure at home too, so he did not experience this type of emergency again. Education will also want to be provided on what makes someone at risk for a hypertensive emergency. This includes having conditions such as diabetes, coronary artery disease, and chronic kidney disease, which my patient had. Another intervention I found that helped to reduce my patient's blood pressure was pain management. This was done by giving him his prescribed dose of PRN Tylenol, which helped decrease his pain and then lower his blood pressure. This slide includes the nursing care algorithm I created based on my critical care patient experience. So at the top, it starts with determining whether the blood pressure measurement is indicative of a hypertensive crisis or not. If yes, then it will need to be determined if end organ damage is occurring or not. So for my patient, the target organ affected was the brain, which indicated a hypertensive emergency. Prior to my encounter with the patient, treatment was done in the ICU to gradually lower his blood pressure with medications. Then when my patient stabilized, to be transferred to the telemetry floor that I had my clinical on, which I marked on the slide with the star. His blood pressure was still monitored while he was taking oral antihypertensives. If blood pressure measurements were to worsen, then the patient may need to return to the ICU. But if blood pressure measures remain at baseline, then patient education is provided. So overall, the questions in this algorithm can be asked to determine if it is a true hypertensive crisis and then either a hypertensive urgency or emergency situation. To summarize my presentation, hypertension is a major cause of cardiovascular disease and mortality worldwide, but it is something that can be controlled. Hypertension is a modifiable risk factor for many diseases, and with poor treatment compliance, it can develop into a hypertensive crisis that can become an emergency if organ damage is detected. When this is the case, blood pressure will need to be reduced gradually with the use of appropriate medications. With proper education and compliance, patients can recover and prevent these experiences from happening.